So today I will be answering essay prompt number 1 and essay prompt number 3. So I will read essay prompt number 1. Part 1. Walk me through all of the steps of depolarization and muscle contraction within the heart muscle. Be sure to address the conduction systems, how we spread signal across the heart, and how we actually exert force. Discuss the concept of heart failure and how imaging modalities may be able to help us visualize the clinical pathology. So, starting with depolarization. Depolarization is where there is a change inside the cell. Typically, the cell is in a negative charge. It has a negative connotation, and it moves to a positive charge. So, we've talked about depolarization in 2 types of muscle this semester: smooth muscle and cardiac muscle. So, I'll go ahead with smooth. So we have a resting membrane of -70 and a threshold of -55. Now, this process, this depolarization, is an all or nothing process, meaning that if the -55 threshold is not hit, then depolarization will not occur. So we start out at this resting membrane potential, and we have this stimulus that allows some sodium to come in, pushing us up towards this -55 threshold. Once we hit this -55 threshold, we shoot up like this and come back down, and then we have a repolarization period into a refractory period, and then we move back up into a resting membrane potential. So what's happening in this is sodium channels are open. So sodium is going to flood the cell. Our cell normally look like this, where we have potassium on the inside and sodium on the outside. We can see that there's less potassium and more sodium. They're both positive charges, but because there's less potassium, that's why the inside of our cell is going to be slightly negative compared to the outside of the cell. So this is where our depolarization occurs. So we see sodium going into the cell. At the top of this graph, we see sodium channels closing, but we see potassium channels opening. This brings us back to a repolarization. This is when potassium is exiting the cell. And then here we have our refractory period, which is our sodium potassium pump. So, with the depolarization occurring, we now have a cell that looks like this. Like that. With our refractory period, we are now taking out sodium and we are bringing in potassium. So for every 3 sodium out, 2 potassium goes back in, allowing our cells to be back at their natural charge, which is slightly negative on the inside with a slightly positive outside. Now, in cardiac muscle, it is a little different. We have another graph here. We have another resting membrane potential, which is -90. And so, excuse me, here we start at the resting potential, but we shoot up like this. We have our peak, but then we start to plateau, and then we go down, and then we go back to resting potential, and we go back up. Sorry, I drew it a little low. And we go back up like that. So we still have our depolarization happening here with our sodium channels entering in. This is phase 4, resting membrane potential. Phase 0 is where our sodium channels are opening, so sodium is still entering into the cells. Then, like normal, we have the top sodium channels are closing, potassium channels are opening. So we see potassium channels open. Excuse me. But we have this plateau on our cardiac muscle that we do not see in our smooth muscle. And this plateau is caused by calcium. Calcium is important, and we will discuss calcium more with muscle contraction. Now, calcium channels have opened, so calcium is entering into our cell. But then we enter into our repolarization phase, which is phase 3 at this point. And the potassium channels have kicked back up. Potassium is exiting the cell more now, overcoming the calcium, which is why we're repolarizing. We're going back to a natural state. Most of this is in a refractory period, meaning that the excitation won't be able to happen while the excitation is occurring, while the current excitation is occurring. So, now, in the heart, depolarization uses intercalated discs, which I will show you with this well diagram that I will draw right here. This is a muscle cell. And I'll do the intercalated disc in a different color. That way you can see. The blue represents our intercalated discs. And what's happening with our intercalated discs is it's allowing the depolarization that's traveling across the motor end plate to move from cell to cell. So, this depolarization, along with trigger calcium, will go into muscle contraction, and the calcium I mentioned up in this graph will come into play in our well diagrams. So this depolarization has occurred in this cell and in this cell. But in order for your muscles to contract, you have these T-tubules which cut transversely into the muscle, allowing the depolarization and the trigger calcium to come into our cell to reach our sarcomeres, which is the end goal. And I will draw another picture of these to show you what's occurring here. But, so the depolarization, the T-tubules, have L-type receptors, which are these 4 lines that I've drawn, okay? On the outside, this is where the trigger calcium binds to, and the depolarization, the electrical current, binds to as well. On the inside, those receptors are attached to your sarcoplasmic reticulum. The sarcoplasmic reticulum holds calcium. So when the feet sense the depolarization and the trigger calcium, sarcoplasmic reticulum gets told to release calcium into the cell, into the muscle. And when this happens, the calcium will bind to our sarcomere, or inside our sarcomere. Which brings me to the next picture that I'm going to draw, because it binds to our myosin and our actin. So I'm going to come over here and draw it. So here we have our actin, okay? And inside our actin, we have binding sites, which are these little black dots inside the cell. And we have our myosin with our myosin heads, okay? Now the myosin heads want to attach to the actin binding sites. But quite frankly, it's just not that simple. We have two proteins that sit on top of our actin and intertwine itself with our actin. The first one being tropomyosin, and it intertwines itself with the actin just like that. So now our binding sites are covered up. Our myosin heads cannot attach to the binding sites. Well, that's a problem. But that's not the only thing. We have our second protein, troponin. So troponin sits on top of, just like that, the tropomyosin. Now I drew three troponin, and I'll label them 1, 2, and 3, because there's 3 different types of troponin. You have TNI, TNC, and TNT. So, tropomyosin is going to be 3. This one right here, because the troponin is bound to the tropomyosin, which is keeping the tropomyosin on the actin binding sites. Okay? We're going to skip 2 and we're going to go to 1 now, and that's troponin inhibiting. And this troponin is inhibiting the myosin and the actin from binding. And then 2 is troponin calcium. The calcium that I was talking about in our well diagram that gets released by our sarcoplasmic reticulum will come over and bind here. This is super important because when the calcium binds to the troponin C, it's the key that unlocks troponin. And because the key has been unlocked, we now have tropomyosin, which is able to unwind itself, allowing our actin binding sites to become clear or free, and our myosin heads are able to bind to it. Now, this is important when we talk about exertion and force and muscle contraction, because this is how our muscles actually contract. The myosin, once it's bound to the actin, will pull the actin back, ratcheting it. So we went from here with our actin and our myosin to now they are able to attach to each other to be pulled closer together, contracting our heart muscles. Now, we can see this through the heart. It will look a little like this. I'm gonna draw us a heart right here. Okay, you have your right atria, your left atria, your right ventricle, and your left ventricle. And here in your right atria, you have your SA node, and I'm going to move that over a little bit. Right here, you have your AV node. Okay? So, your SA node is very important. It's also called the pacemaker of the heart, and it depolarizes itself, meaning it does not need a stimulus. It does not need sodium to depolarize it. It depolarizes itself at 100 beats per minute. Excuse me. And because of these intercalated discs, that depolarization can look a little something like this. Down the atria, okay? So that's what depolarization looks like in our atria. I'll go ahead and I'll draw us a EKG because we can also see this pictured in our EKG. We'll start here. Oh, that was bad. Like that. Okay? So, here in our EKG, we can see our SA node depolarize. Okay? Because our SA node has depolarized, in our P wave, we see atrial depolarization. Now, depolarization does not mean contraction, but normally contraction does, especially if it's excitatory, contraction does follow depolarization. So because the SA node has depolarized, the calcium has been released, allowing for contraction through the atria. Your atria will depolarize down, pushing the rest of the blood, 30% of the blood, into the right and left ventricles, because 70% of the blood passively fills the right and left ventricle. Okay, now we have our AV nodal delay. And it's this little flatline piece that you see right here, okay? So we have our AV node, and it slows down our depolarization. And this line right here, it will represent a layer of electrically dead cells. So that depolarization can hit this line, but it's not going to move past it, okay? And this is important because it allows our ventricles to have that fill time to get that 30% that's been contracted from our atria before our ventricles contract upwards, okay? Then we have our QRS complex, okay? This will represent ventricle or ventricular depolarization. Okay? So, from the AV node, once our ventricles have had enough fill time, the depolarization in green will go through the bundle of His to the bundle branches, which will branch off just like that, and into our Purkinje fibers. Now, on our QRS, the Q to the R, are our bundle branches, because if we were looking at an EKG, it has to do with where the leads are placed, with where the with where the stickers are being placed. So it's positive because the bundle branches are going towards the lead. That's why Q is going up to R. Okay, but from the R to the S, we have our Purkinje fibers. So our PKF, our Purkinje fibers, which would be these green lines right there. And these lines are important because it's what allows our heart to contract upwards. Ventricular depolarization is so big because the ventricles, like I said, are contracting upwards. So our right ventricles are trying to get to our pulmonary artery, to our lung, and the left ventricle is trying to get the blood to the aorta. Well, now we're working against gravity because we're pushing up. So the contractions need to be a lot stronger with our ventricles than with our atria, who's working with gravity, allowing it to flow down, right? But in this time, we see atrial repolarization, okay? So the atria is resetting, it's at the beginning, it's back to its natural state, being ready to receive blood and contract again. And then we have our T wave, which is ventricular repolarization. This is when our ventricles have reset, they're back to normal, ready to be filled and ready to be contracted again. That is how depolarization, muscle contraction, and force exertion work inside the heart. Now, for part 2 of this question, we're going to talk about heart failure. So, what is heart failure? That's a great question. Heart failure is when when your heart is not able to adequately supply blood flow to your body. Okay? Now, there are 2 types of heart failure that we will be discussing, but before I get into that, the top 2 causes of heart failure is myocardial infarction, which is heart attack, and coronary artery disease. Okay? So, with the first type of heart failure that we will be discussing is HFrEF. And I'm going to leave this picture of the heart up because we can use it again. It's HFrEF. Now, the HF stands for heart failure. The R stands for reduced, and then the EF stands for ejection fraction. Ejection fraction is how much blood the heart is able to pump out. So how much blood is going to the lungs, how much blood is going out of the aorta to the rest of your body. That is ejection fraction. Now, with ejection fraction, nobody is ever at 100%, okay? But normal people with, people with healthy hearts, their ejection fraction's probably closer to 95, 98%, right? It's like squeezing a juice box, a full juice box, with your dominant hand with all your might. All of that juice, or most of that juice, if not all of that juice, is going to come out of the juice box, right? Well, with reduced ejection fraction, it's going to be less than 50%. So, what this means is that we're filling the heart, we're filling the ventricles, specifically the left ventricle, with blood. It's being completely filled like it normally would. Right? So it's filled with blood. What this means is that there's been some sort of cell death, and which is normally caused by an ischemia, which is where not enough oxygenated blood has gotten to those cells. So we've hollowed out the heart wall, meaning we don't have as many myocytes as we once did to contract the heart to push the blood out. Blood is coming in just fine. It's filled. 100% of the blood is there. 100% of the blood is able to be there. But you can't contract it out. So we see a decrease in our Frank-Starling curve, which is preload, and we see a decrease in stroke volume, which is not good for the heart, which is not good for cardiac output. This has to deal with systolic. This is a systolic problem because systolic deals with contraction. So we have a problem with contraction of the heart. Now, the second kind of heart failure is HFpEF. Same thing, same thing, but the P, heart failure, is the HF, but the P is preserved ejection fraction. With this one, this means that your ejection fraction is above 50%. It's greater than 50%. So here, this is a diastolic problem. We're not having trouble with contracting the blood out. Here, we're going to have trouble with the filling. And that can be caused by your heart is not relaxing like it should, or added sarcomeres. So what we've done is your heart may not be allowing enough fill time, but also you could be adding too much muscle to where now your ventricle, instead of it being with the regular red, looks like this. And this is the amount of space that blood can fill. Blood, like I said, it's not a problem with contraction. You can still get the blood out. You have more than enough muscle to contract and squeeze the heart to get the blood out, but you don't have enough room for all of the blood that you would normally be getting with a healthy heart. So those are the two types of heart failure. Now, how can we see the different types? How could we see heart failure? How could we see what is happening in the heart? Well, through the semester, we have talked about different imaging modalities, and while I'm erasing, one of the ones that we talked about was X-ray, but that really won't necessarily help us with the heart. That's more, for bones, if your bone was broken. And we've talked about PET scan, and PET scan is good, but it's very dangerous. It uses radiology, and in all honesty, it is more for metabolism. It allows us to see metabolism, and you don't get anatomical borders, so you can't really see the heart or the liver or the pancreas or whatever tissue or organ you're looking at. You just see where they've been metabolizing and intaking glucose. So the first one I'll talk about that gets used for the heart is ultrasound. Ultrasound is probably the easiest. In fact, many of you probably have had an ultrasound done on your heart already. But what it does is it takes a little, it has a transducer, which is what I am drawing on the board. And it uses sound waves. Now, this transducer is usually hooked up to a laptop so we can see the picture afterwards, right? And we're looking at the heart. So basically, the transducer at the bottom, at this part right here, it has little piezoelectric crystals that can be slightly disformed, meaning they can be squished, they can be elongated, they can be rolled, and they can move around, allowing the sound waves to come out at different places. The sound waves, they start out small when hitting your skin, but they disperse through different tissues. When you see a bright white spot on your screen, you know you've hit bone, because bone does not allow sound waves to penetrate. So, you can use an ultrasound to see your heart, but there's a trick to it, because your heart is directly, from the front, directly underneath your sternum. So if you were to put the ultrasound right here over where your heart is located, you would see just a bright white space, because you would just be seeing bone, because your sternum is there. Same thing from the back. In the back, you have all of your ribs. That's protecting your heart. So that would make it difficult to see your heart and give a clear image of your heart too. So what they have to do is they'll take it and they'll angle it to where it's underneath your diaphragm, and it'll give you a frontal plane view of the heart. Now, this is really cool because it allows us, it works in vasculature as well, so we can see blood flow. We can see if the blood is coming to or going away from the heart. This, we can see if enough blood is being contracted out we can see if it's a systolic problem, but we can also see if there's too much blood in the vasculature being backed up because there's a filling problem with HFpEF. That's how we can see the heart with ultrasound. Now, the second type is probably the best way to go, and it's an MRI. It's a lot safer than a PET scan. It uses magnets. It's very loud. It stays on all the time. But what it does is all of your cells have a polarity. All of your cells have a charge, okay? And what it does is it takes all of those cells, these are my cells, all of their poles, and it points them into the same direction with the magnet. These magnets are very strong, okay? Then it uses radio frequency to knock out one of the cells from the direction it's being pulled by the magnet. So now your cell is down here. The way we get pictures of our heart from this is through the precession, is through how this cell travels back to get here. And we can use cameras, we can take stop motion pictures to look and see the heart. But with this, we should be able to see if the heart is thickened, if the wall has thickened because we've added more sarcomeres, or if the wall is hollowed out because of cell death. That is how we use imaging to see the heart. Okay. So this is essay prompt number 3. It says, imagine you are working in your dream career and consulting with a patient. The patient reports into your facility for a first appointment, and upon reading their medical charts, you see the patient is 56 years old and has been diagnosed with myocardial infarction and has recently had bypass surgery. You scan down the medical history and see the patient is on a long list of cardiac drugs, including a diuretic and an emergency vasodilator drug. What precautions should you take with this patient when in an exercise facility, and how do you expect exercise to be tolerated in this patient? Be sure to discuss the cardiovascular effects of exercise. So, I figured that I would start with cardiovascular effects of exercise because you have cardiovascular effects of exercise in a healthy human, but you also have them in the unhealthy human as well, and unhealthy, people with heart problems. So, regular cardiac effects, you're going to see an increase in cardiac output. And this increase in cardiac output is caused by an increase in heart rate and an increase in stroke volume. You're going to see an increase in both of these things, okay? You're also, you're also going to see an increase in your mean arterial pressure and your pulse pressure. This is because your mean arterial pressure, for the mean arterial pressure, you're going to have more pressure inside your arteries because you're taking more blood away from the heart to the working muscle. And then your pulse will go up as well because, your heart rate has increased. We're going to see a maintenance of central venous pressure, and this is done by your skeletal muscle pump, and it increases preload with the Frank Sterling mechanism, and it's the first one, and it alternates constriction of the veins, right? Then you also have your abdominothoracic pump, which also increases preload, which is part of your stroke volume. It increases preload. And it's the second thing that comes to the rescue when rescuing cardiac output. We also, while cardiac output is increasing, we see a decrease in systemic vascular resistance. Systemic vascular resistance equals constriction. If there's too much SVR, then there will be fainting. And obviously that is problematic with or without heart problems, but especially with heart problems. So let's talk about our patient. Our patient came in and he had a myocardial infarction. Myocardial infarction is just a fancy word for heart attack. This occurs because there's a lack of oxygenated blood going to the heart, meaning that there is cell death here. So, we have our arteries that normally look like this, right? Okay, blood can go straight through them. With heart attack, because it can be caused by coronary artery disease, which is where the artery gets inflamed and it gets backed up and clogged with fatty acid or plaque, that artery is going to look a little something like this, and we'll elongate that at the end just a little bit. So you see the difference? Blood in this artery, the normal artery, healthy artery, blood can go straight through. As to where in this artery, blood can't just go straight through. Blood has to go through this tiny space right through here. Well, we have a lot of blood, especially in exercise, right? And a lot of blood that needs to go to the rest of the body just in general. So this is a problem in all reality. So to fix, also backing up a little bit, this inflammation is caused by arachidonic acid. It causes the inflammation of the arterial wall to meet the other arterial wall, okay? So to fix this problem, I'm going to erase our normal artery picture. We see that our patient has had a bypass surgery. This means what a bypass surgery is they harvest a vein from either the mammary or from the front of your leg, and they attach the artery here and here, right? And so normally this vein is the great saphenous vein that gets used. And so what this does is it allows blood to have another route going around the inflammation, getting to the other areas of the heart that it's needed to get into, okay? Because like I said, if it was just this, not all the blood is going to be able to get through, which is why we have a cell death in the heart, right? So with this, now the blood can go over the inflamed spot and make it to the other areas of the heart that are not dead yet, right? So they have drugs that they can use. They were put on a diuretic. And in the simplest terms, a diuretic makes you go to the bathroom faster. Makes you go to the bathroom faster. Or more frequently, I could also say. So, what this diuretic does is it takes, and why you go to the bathroom so much faster is because we're taking excess blood and excess fluid that's just sitting there, that's been backed up because of this, and we're excreting it. We're taking it, that is following the diuretic, but it's following the diuretic out of the body as urine. So, this is very important. People use this for heart failure too, to help. Then they were also put on emergency vasodilator drugs, right? So a vasodilator drug, because it's emergency, they're not just taking this drug. They take this drug if there's a problem with constriction. Because what this drug will do is it's going to take a vein or an artery, right? Like here's our vein and artery, and that space right there is the space that blood can travel through. But what this is going to do is it's going to open up that vein and artery, allowing there to be more space for more blood and more fluid to flow through. Now, we may need the emergency vasodilator because of how much fluid is being excreted, being moved to be excreted. If your other arteries and veins are fine and they're at their normal size, well, the rush that they're getting from the extra fluid that they're getting is going to rock their world in a way, and it's going to be a little bit more difficult for all of the blood and all of the excess fluid to make it to be excreted, right? Or harder for the blood to make it back to the heart in general, which is not good. And that brings us back to our problem at the beginning, right? So when exercising, we are going to have to take some precautions. We are, especially because our patient just went through a medical event. Like, this event is no joke. It's serious. It takes a toll on the body. They're very tired after this, but we have to exercise. We need them to exercise. We need them to rehabilitate so the heart gets stronger. So this pathway gets used to having blood pumped through it. But we are going to start off slow, and we are going to start off with mild exercises just because our patient is going to be immune to fatigue. They're going to be tired a lot quicker than if they were a healthy patient coming in, right? Because like I said, their heart just went through an event, a traumatizing event, okay? But also, with the diuretic that they're on, we're going to need to know that our patients are going to have to use the bathroom a lot more frequently, right? So instead of having like a 10-minute, interval of an exercise of running on the treadmill, or of jogging or light walking on the treadmill, because it is his first visit or her first visit, we may have to make it a 2 or 3 minute light walk on the treadmill, because they have to go to the bathroom much quicker and much faster because it's moving, right? One thing that I forgot to mention with the cardiovascular effects is that blood flow does get redistributed during exercise, meaning that when I'm at rest, when I'm sleeping in my bed, I have blood flowing to my stomach, my intestines, and my gallbladder and my pancreas a lot more than when I'm exercising, because we want blood to go to the working muscle. And so the priority has moved away from digesting the food that I ate 2 hours ago to my working muscle, my legs, my arms, if I'm, doing push-ups or, pull-ups or whatever. So that is how that's how cardiovascular effects are in exercise, or is affected by exercise, and myocardial infarction affects all of this because, well, you cannot exercise the same way that you exercised previously when you were a healthy human. You have to be more careful and more aware, especially as their physician or as their the person they're coming to work out with. So, thank you.